Hi everybody. I'm doing the screencast as I mentioned last week, and to try to keep us a little bit on track, maybe even catch up a little bit. I know I did talk ever so slightly in regards to this slide set last week, but I thought I'd start back at the beginning again anyway, just to work our way through it. So this is our first technique we're going to learn about of a few, and these are superficial reflex and superficial fluid techniques. The things we need to think about, and I've used these terms a few times, and I know I've gone over this, but as a reminder, we have indications, contraindications, and cautions. Of course, indications represents a sign, symptom, evaluation, or diagnosis that allows you to apply techniques for, and there's many for those. So we're saying that it's indications for massage therapy. So you look at, whatever may come into your office or into the clinic at the school, you have to then determine the issue or the clinical presentation that the client or patient has when they walk into the room. Is massage therapy actually indicated, or the techniques that you know actually indicated to help this individual and their concerns or their clinic presentation? Contraindications are the exact opposite of that. So it's a sign, symptom, evaluation, or diagnosis that directs the therapist to avoid certain procedures. So I think you've already talked about a few of those, and we can remember we can have a general or specific contraindication. So or local. So it could be that the condition that the client has, you can't touch them anywhere at all based upon that. Whereas in some cases, they may have something that is associated to a small area of the body, and that area would be contraindicated, so that would be a local contraindication. Cautions are any sign, symptom, evaluation, or diagnosis that directs the therapist to be prepared to modify a given procedure in order to reduce the risks associated with its applications. For example, pregnancy, hypertension, those sorts of things. So you can still treat the patient, but you would have to modify your techniques and or the position of the client on the table in regards to your treatment. When we look at a treatment, I talked a bit about this last week and sort of gave some demonstration, be it minor. We have to sequence our massage techniques so we're fluidly running from one technique to another. So first, summarizing clinical findings and outcomes. So we do that through history assessment and what body structures will be treated, functions affected. So, we've got to think about, based upon our clinic findings and the outcomes that we chose along with the client for the treatment, we have to consider what structures will be treated, what functions are affected, and then once we kind of have that part done, then we select the techniques that we're going to choose. So they're chosen specifically to achieve those outcomes that you thought about. Now, remember that we can have outcomes that are at the end of the full treatment plan or the plan of care, but we also have to consider what's happening today and what we're going to do directly with our client when they get on the table and we walk in the room and we begin our treatment. So are they indicated then for client health and safety? So as I said, local versus general. So keeping in mind, whatever you talked about with the client, are you going to be contraindicated or cautioned, or is everything indicated? And of course, specify scope and duration of sequence of massage techniques. And I talked a lot about this last week because I think it's important for students to understand what is your scope at the time that you're doing it. You have very little scope right now in semester one, of course. You're just learning the techniques. In two, you'll have a bit more. We feel that you've got enough in three to start actually treating the client, be it for a wellness treatment, but you still have enough of a scope. In other words, you know enough techniques and understand massage enough that you can perform a wellness treatment to your client. So specify scope and duration of sequence of massage techniques. That can run all the way to when you are a massage therapist, where you may say to yourself that the condition that my client's presenting with today, I can't treat them at all. I don't have, it's not within my scope to be able to provide care for my patient or a treatment for my patient. So again, when we look at it then, and we think about all the things we're putting together, we then have to apply all these principles of massage. And I have said this over and over and over again, is you need to know these ultimately outright. So this is general, specific, general, superficial, deep, superficial, proximal, distal, proximal, and peripheral, central, peripheral. These are a principle of how you apply your techniques from a general perspective to a specific and back to general. superficial, deep, superficial. And we're going to go through all these as we work through the slides here. But I have said to you a couple of times that it's vitally important that you remember these and understand these. Okay, so let's talk about general, specific, general first. General is engage and provide information about a large area of the body or a large group of tissues. So, we look at it from a very large area that could be an area that surrounds the condition that the patient has or the area that you've identified you're going to apply a treatment to. Specific is small contact surface, smaller amplitudes. So rather than big, broad strokes or big, broad techniques, we get down into smaller applications of those techniques. In other words, we're focusing on localized tissues and body parts, and therefore we have to consider, again, within contraindications or cautions, do we in fact actually have the ability to be very, very specific in certain areas of the body? Could be that within the context of the injury, there might be an area within there that has, say, for example, an open sore or a wound site where there may have been stitches from a surgical procedure or something like that. That would be something that would be a local contraindication. So your specifics might be a little more difficult in that. So you might work generally around where that application or that surgery was, but you wouldn't, of course, specifically work in the area of the surgery itself. So this permits assessment of broader areas. So of course, we're thinking about intelligent touch. So when we're applying, we're assessing the tissues with those 5 T's as we're providing this broader area. The effects level of the client's arousal, alertness of tissue, and awareness. So something that I would normally do in class is ask you to partner up, apply pressure with the broad flat of the hand, apply the same pressure with 3 or 4 fingers, same pressure with 2 fingers, same pressure with 1, and then get feedback from the individual, the partner, to, what did the depth feel like, or how specific did it feel, and so forth. It helps accustom to the therapist's touch as well. So when we start general, you've learned effleurage, for example. It's application of the lotion. It's an initial touch with the patient, and they feel better. But when we work general, specific, general as well, it helps to prevent post-treatment pain. It is less invasive, and it really lowers the probability of something called kickback pain, which is, again, you do your treatment, you apply your techniques, and the next day the patient is, informed you a week or two later after appointments that, 1 or 2 days after treatment, they were very, very sore and had a sort of a negative reaction to your techniques. You may not have done general, specific, general enough, and you didn't sort of, shall we say, finish off appropriately. Superficial, deep, superficial, it sort of explains itself. So of course, superficial, we're near surface on the body. It's a lighter pressure. It accommodates to touch, affects conditions on surface before affecting deeper layers, such as skin, lymph, and superficial muscles. Please be aware that you may have the impression that superficial touch, it does not cause great effects. You couldn't be more wrong. I had an opportunity when I was at school where I had someone treat me, and end of the treatment, I went to the clinic that we had when I was a student and was treated by another student, and I felt it wasn't deep enough. I thought they were far too superficial with me, and I didn't think it would affect any change. And I was quite pleasantly surprised that I did feel better, and the next day felt even better again. So again, as I say, don't think that superficial doesn't have an effect. We still need deep work, but superficial does have an effect more than you would realize. Deep, of course, is an increase in pressure, treatment of the deeper layers, such as a deep muscle or deep into a scar tissue or those ligaments that are deeper within the context of the area that you're working. It helps accustom to the therapist's touch as well, starting superficial to deep, and the same as going back here to going to general, specific, general. Same thing in superficial, deep, superficial. Helps to prevent pain. It's less invasive, and you really do prevent that kickback pain. Again, applying these techniques and these principles. Next is proximal, distal, proximal. So proximal is towards the axial body, always begin proximally. So if we're thinking of a limb, whether it's an arm or a leg, we always begin our treatment proximal in that limb, and then we work distally. Always proximal, work distally. This opens up lymph channels improves, and by dilating blood vessels, improves venous return from the area that you're treating, those sorts of things. So we work proximal to distal, but we always have to remember we're applying our technique proximal to distal, but our pressure is always towards the heart. So we're never ever pushing fluids, say, down towards the foot or out towards the hand. We're always coming back proximally with our pressure working towards the heart. So again, start proximal, work to distal, but pressure is always towards the heart. This type of principle encourages circulation and venous return, as I said, through centripetal pressure. It's always a bit lighter on the return stroke than it is on the backstroke. We want to loosen the proximal furts, and as I said, this increases circulatory efforts such as blood vessels and lymph vessels. Peripheral, central, peripheral. We always work away from the center towards the center. It allows you to palpate related tissue changes. Gradually introduces massage techniques that may be tender. Again, important for flow of fluids, especially lymph. Think of a healing bruise or localized edema like a sprained ankle. We would work peripherally around the sprain and then work our way towards the edema. If you had a bruise, of course, if a bruise is relatively acute, you'll learn this a bit later, is that depending on the age of the bruise, if it's very, very acute, we don't go into the bruise tissue at all. But we do work on the outer borders of the bruise, helping promote drainage and so forth. So when we look at these principles, we have to look and understand what we're doing here. When we're looking at, when we're looking at techniques, we have to understand the kind of effects that it's having on the body. So in general, reflex of a massage, we don't have mechanical effects. We have a nervous system that's stimulated. So we are in general reflex effects, we're stimulating the nervous system for relaxation and so forth. So when we touch, in general, we have peripheral receptors that lie within the skin and muscles and fascia, and these send impulses to centers in the brain or spinal cord, which then cause a local or systemic response. So for example, stroking a person's hand at the right rate and rhythm can cause drowsiness, for example, or you do it with a child, gentle rubbing of the back and so forth, trying to put them to sleep. When we look at these general mechanical effects, they're caused by physically moving tissues, mechanical effects. So we see general reflex is the nervous system affecting the nervous system. Mechanical, think of it as actually physically moving the tissue. Here we're doing light things that we're stimulating the nervous system. Here we're doing things where we're actually physically moving tissues. And we can do this by compression, by stretching, by doing something called shearing, bending, or twisting. So if we have, for example, a significant scar, we would want to stretch that scar to get it to lengthen so that the range of motion won't be as affected by that scar. So we can see when we look at tissues here, we have this cross section. I know we haven't gotten into skin yet in A&P, but we can see a cross section of skin here. And you can see we have this epidermal layer on the top, and then we have the dermal layer, and you'll see underneath we may have some adipose tissue. We talked about it a little bit in A&P. We've got connective tissue, we've got the basement membrane, and deep to that we've got blood vessels, nerves, muscle here, and bone and ligaments and so forth. The reason this is kind of here is to understand that when we're mechanically moving tissue, we are actually affecting many, many layers down much deeper than you would realize when you're applying your technique. So we say, we've got the epidermis, dermis, adipose tissue, connective tissue, blood, nerves, muscle, and bone, and they all get affected when we apply these techniques. When we look at these techniques and their terminologies, first we have superficial reflex, and these only engage the skin and can produce these reflex effects we talked about, but no mechanical effects whatsoever. Superficial fluid techniques, these engage the skin, what we call superficial fascia and subcutaneous fat, down to the investing layer of the deep fascia. So we're getting down a bit, but not significantly down into tissue. it produces mechanical effects on superficial lymphatics and possibly venous circulation. In other words, superficial fluid techniques promote lymphatic drainage or the movement of lymph fluid, and lymph fluid is always moving from distal to proximal towards the heart. Neuromuscular techniques, these engage muscle and the tissue it contains. They affect the function of the contractile elements of muscle tissue, also the connective tissue by rehydrating it, and we're going to talk a whole lot about that in A&P. And as I said, increases lymphatic return. They can also produce some complex reflex effects, which we'll get to a little bit later, and I'll talk a little bit about reflexes again in Clinical Anatomy 1, sort of in the second half. Percussive techniques are exactly like it says. If you are a music person, played in a band or something along that line, you know what the percussion section is. The same idea is it's sort of the striking type of techniques. So it goes on to deform and release tissues quickly. Depending on the force that you use, you do engage different tissues and how you apply them. Also, believe it or not, can get useful reflex neuromuscular effects. So these striking techniques can actually calm tension down in a muscle. Connective tissue techniques, they engage superficial and deep layers of connective tissue. They mechanically affect the rehydration, extensibility, meaning lengthening, and modeling of connective tissue. They can also produce complex reflex effects as well. And then we have passive movement techniques. These produce substantial tissue or joint motion without effort on the part of the client. So this is, what we talked about with range of motion. This is the therapist doing the movements. It engages multiple tissues and structures and have wide-ranging effects on fluid flow, connective tissue, and the neural control of muscle tone. So think about, your clients on the table. You're working with them, and you're doing all the movements of the limb. They're not doing anything that you're trying to possibly increase range of motion. We know that the movement of limbs promotes lymph flow and so on and so forth. So when we look at the 5 techniques of Swedish massage, we have effleurage, which I believe you've taken, petrissage, I think you might have been just introduced to, vibrations you guys said you've done, these percussive techniques, also known as tapotement, and we also have frictions. Now frictions you will not be doing this semester, but they will be coming down the pipe. So when we think about these techniques of Swedish massage, again, and we think about, this taxonomy of passive movement, connective tissue, neuromuscular, percussive, and superficial reflex and superficial fluid, we have to think of all these structures that we can have to consider, from bone, ligaments, muscle tissue, and so forth. Now, when I went to school, just to let you know, these terms did not exist. So we didn't have these superficial reflex techniques, superficial fluid, and so forth. We knew them as these ones: effleurage, petrissage, vibrations, percussive, and friction. So things have moved on as they should, and we don't use these older terms anymore. We use the new terms. Okay, so let's talk about superficial reflex techniques first. And I know you've practiced some of these in the lab setting. So obviously superficial means pertaining to or situated near the surface, of course. And then reflex is this involuntary reaction that's a response to this stimulus that you applied to the periphery and transmitted to the nervous centers in the brain or spinal cord. So just strictly from just touching skin, that message of the touch will head off to the nervous system, eventually to the spinal cord and then the brain, or one or the other depending on the reflex, and then you'll get the changes that you're after. So they engage only the skin, and again, these reflex effects, but no mechanical. We're not twisting, bending, turning, or anything like that with any of those tissues. It can affect the level of arousal. It can bring what's called autonomic balance. Now, when we think about autonomic, we're talking about the sympathetic and the parasympathetic systems. So, superficial reflex techniques, if someone's in a high anxious state, they're within the autonomic nervous system, their sympathetic system is on high alert. And through using superficial reflex techniques, we can actually start to stimulate parasympathetic response, thus lowering sympathetic hormones and so forth, and allows the patient to relax down and become less stressed or less anxious, or so forth. I've seen it actually work very well in the hospice setting, that providing superficial reflex techniques can calm someone down considerably. It can also change a patient's perception of pain. So from a very high number, oh, I'm in much pain, and then through superficial reflex techniques, you can actually calm that down. If you think about it, when you hurt yourself, you do sort of provide touch to some degree to help lower any discomfort you have if you have, hurt yourself in some way. This includes static contact as a technique, superficial stroking as a technique, and fine vibration as a technique. So let's do static contact first. You can see that you've got a couple of different ones here. So in this case, you might be helping the patient to diaphragmatically breathe. And you can see the two hands here, for example. The therapist would be identifying to the patient that the rib cage is expanding a little too much, so they're lung breathing and not engaging the diaphragm. Whereas the therapist could say to the patient as you're breathing to, please push against my lower hand, bringing your stomach up towards the ceiling. And what it does, through touch, it actually gives feedback to the patient to recognize that area, because they may not even think about it. Over here on the left, this is a static technique that's used on the occiput. This is known as posting or still point. Still point comes from craniosacral therapy. That's sort of a term that they use, that they just literally put your hands underneath there, have the occiput just sit on the pressure of your hands, and you don't move. And you just use the weight of the head to help stimulate a reflexive reaction just through the sheer fact of posting. So motionless contact of the therapist's hands with the client's body, and it's performed with minimal force. I think I told you guys I used to do a lot of static contact techniques. I found they worked very, very well. What I liked about them was that when you applied a static technique to a very sensitive, sore area, if you moved, it would just increase the pain or make the perception of the pain be continuous. With a static technique, the patient does perceive that initial discomfort or pain with the touch, but as you just hang in there and don't move, their perception comes down considerably, the tissues calm down considerably. It's a very effective technique. So this again is motionless contact of the therapist's hands with the client's body, and there's minimal force. It is the least mechanically forceful of all the massage techniques. It is an important part of systems such as therapeutic touch or Reiki, which only level 1 is within our scope. Also, superficial reflex static contact is also a part of craniosacral work, or in some cases osteopathy. So we use this to increase rapport, so the patient is, kind of getting a sense of you. It's also a great introduction to your initial touch with your patient. As I said, it really decreases anxiety, it improves relaxation. It does work as an analgesia, it does lower pain perception. It may improve growth of premature infants. So there is some research that shows that static touch on premature infants increases growth and increases suckling. So literally just statically touching a newborn preemie will increase the growth of that child and increase its ability to suckle. If a child's born very young, they don't have the ability to suckle. They're not mature enough yet within their nervous system, but the static touch does get that nervous system activated quicker, and the child will move to suckling faster and as well growth overall. It's also used to assist with client education. And if you look at it from some different philosophical perspectives, it can affect the client's electromagnetic field. It is contraindicated in areas of acute inflammation because of pain. Obviously, it's not something we'd put directly on the inflammation, but you can use it below the acute inflammation. So if you have a knee that's all blown up, with inflammation for some reason or other, you can apply static contact, shall we say, below here, because it does not cause an increase in circulation. So it would just be a static touch to that area. Also, clients who have much pain or distress may not tolerate touch at all. So be sensitive to the needs of the frail, high risk, or terminally ill clients when you're thinking of it. And even though static contact causes minimal and mechanical effects, it can give rise to complex physical and emotional responses including touch-triggered memory. These are emotional releases. I'm going to talk a little bit about that when we get into class because I think it's something that we all need to discuss. I'm sure it's even been brought up in your lab setting to make you recognize that when you're working with each other, your techniques and touch with your partner could elicit emotional responses within the context of the lab. And I think we need to have a brief discussion around that when we get together. Performing it, of course, you use a relaxed upright posture with fully relaxed hands. You breathe using your diaphragm. You're encouraging relaxation and diaphragmatic breathing in your client so that they're stimulating their parasympathetic nervous system to calm down. You do look for signs of relaxation. And for relaxation response, try applying static contact to the client's occiput, sacrum, face, hands, or feet. It really does bring them down quite a bit. Superficial stroking. Okay, everyone, so we've done the static contact, and again, another one I think you've done in the lab is superficial stroking. So obviously this is gliding over the client's skin with minimal deformation of subcutaneous tissue. So there is some light pressure that does occur on the skin, usually applied unidirectional over large areas of the client's body. So, the hands are moving, and we have to think of our principles, right? What direction would they be moving in most cases? And often used at the beginning or end of a region or intervention. So I know that some therapists will begin their entire treatment before they even put lotion on. They'll do superficial stroking, and then they'll apply lotion after the fact, and then they may finish with it as well. We can see it here that the therapist is starting up near the trapezius area and is stroking from the cervical spine down towards the sacrum in the stroking technique. And this is palmar stroking, so the whole hand is in contact here. You can also do fingertip stroking as well, depending on the area and what you're trying to, what your goal is in terms of applying the technique. So it reduces pain, it improves mood, it reduces anxiety, like all the other superficial techniques. It can change the level of arousal. So if done very slowly, it is calming. If we do it quite quickly, it actually increases alertness. There's some thoughts that as part of the static, superficial stroking also improves growth of premature infants. It can possibly alter the level of neuromuscular tone. So if you find that the muscle structures have high tone, then applying superficial stroking can lower that tone to some degree. It is, again, the same as static, contraindicated in areas of acute inflammation, and that has to do with the pain. Clients who have much pain or distress may not tolerate touch at all, so you have to be very aware of that and be sensitive to the needs of frail, high-risk, or terminally ill clients. And so you have to think about that. We don't use it in a recent myocardial infarction because we could possibly be moving fluids towards the heart, and the heart is having enough struggles after having had a heart attack, which is what a myocardial infarction is. We also, within 48 hours, we have to wait 48 hours after they've had a bypass surgery, which is an open heart, in most cases an open heart surgery where they bypass plugged arteries in the heart. We'll talk a little bit about that in A&P. And if they're ticklish, I can't tell you how many people I've met who can't tolerate a number of these superficial techniques because they're so ticklish. It's just too stimulating for them. So ticklishness, try a broader contact, try more lubricant if using, or more pressure, or avoid altogether. So I have found myself that if they are very ticklish, if you just apply a little more pressure, they don't tend to perceive it as tickling as much. So again, that's that. So performing sedative stroking, so remember, it all has to do with speed. So if we're going quickly, we're stimulating a relaxed contact with the entire palmar surface in a very slow, stable rate is more sedative, and moving in a caudal direction, so down the limbs and back towards, remember caudal is tail, down towards the pelvic region. Stimulating is more fingertip, very irregular, very fast rate with multi-directional stroking. So this is very unidirectional, moving in one slow, stable speed. This is more fingertip, so less contact, very quickly, very irregular, and in very many directions. It will stimulate. Quite often we'll use this in what we call pre-event. So if we're trying to stimulate muscle action, prior to a sporting event, we'll use stimulating stroking. When the event's over and they finished, such as a marathon, then we would use the sedative style to calm the muscles down after having done the sporting event. Vibrations, I know you guys have told me you've done these. So these are fast oscillating or trembling movements that are produced on the client's skin with minimal deformation of subcutaneous tissue. So you're not applying it heavily on the body, you're just lightly over the skin, providing it. The manual, it's hard to perform long enough to be effective. It takes a lot of muscle contraction to do so. It takes a lot of practice to last a period of time. And for many of you, your dominant hand won't have a problem with it, but your non-dominant hand might struggle a bit, so it takes some practice. Perform using a machine that vibrates at 100 hertz. There is a couple of machines out there. I'm not keen on machines. Machines do have effects, neuromuscular effects. The only problem with machines is you don't get the feedback. You don't know what's happening to the tissues while you're applying it. But many therapists do use machines as an introductory to their techniques. And fine vibrations is one of the traditional Swedish techniques. It is an analgesia for both acute and chronic pain, so it does lower pain. It also improves the ability of clients with neurological problems to perform exercises, though temporary raised. So when you vibrate, you're raising tone, and the patient will be able to improve their ability to perform an exercise, but it is only temporary in nature. When pain is due to acute inflammation, the weight of a hand or of a machine may be not tolerated locally, so that would be that will be either a local contraindication or caution depending on the client. Next are our superficial fluid techniques. So when we think of these techniques here, when we're talking, looking at these superficial ones, these are all neural in nature. So they're stimulating the nervous system in certain ways. Our superficial fluid techniques, of course, these are things that are going to mechanically alter the tissues to promote, as we see here, fluid returning to lymph and venous blood returning back to the heart. But it is superficial, which means that it is pertaining to or situated near the surface of the skin, but we do move things around. So they have the ability to cause mechanical effects through compression and stretching of vessels. They also have reflex effects as well, because they, within the context of these techniques, they do stimulate cutaneous afferents. Afferents means towards the nerve, towards the spinal cord and brain. So these are sensory organs. These are things that send messages with tickle, pressure, and so forth. And then within the context of reflex effects, we have the rhythm and tempo, like we had in the other superficial effects. That rhythm and tempo has either a stimulating or sedative sort of stimulation or affects the nervous system to either be sedative or to be stimulating. So these are applied to tissues, superficial to muscle, to increase the return of flow of blood or lymph. Now, if we go all the way back here and we look at this picture, we can see that we've got a number of structures running from skin down to muscle. Of course, muscle is represented as red here. So you can see what we're talking about is we're affecting these tissues here, not affecting muscle and ligaments and so forth. So, I went a bit too far here. So we've got applied the tissue superficial to muscle to increase the return of blood and lymph, both of course back towards the heart. This includes something called superficial effleurage and superficial lymph drainage techniques, which you will not be taking until semester 2 or next semester. So let's do effleurage first, which I know again you've done. It is a gliding technique performed with light pressure in the direction of venous and lymphatic flow. Remember how we talked about proximal, distal, proximal, but always our techniques are moving towards the heart. This is an example of it. So gliding technique performed with light pressure in the direction of venous and lymphatic flow. It does deform the tissue down to the investing layer of the deep fascia. So it's enough of pressure that we're affecting some deeper structures, but not firm enough that we're actually affecting muscle tissue down below. So the next time you're working in lab and you're performing the technique, I want you to sort of mindfully kind of figure out where you're at in the depth of the tissue, get an understanding where the muscle is. Try not to go down into the muscle when you're performing this. It does affect the layer of superficial fat and fascia, which contains, of course, many veins and lymphatics, hence the reason why it promotes the movement of lymphatics and venous blood. Traditionally, effleurage is one of the traditional 5 Swedish techniques. So we can see here, again, you can see they're moving towards the heart in both of these. So in the case of the leg, from the foot towards the gluteal region, in the back, upwards and opening this way. All right, so again, moving towards the direction of lymph and blood flow, always moving again towards the heart. So outcomes, it increases return of flow of lymph and venous blood. It helps to reduce edema. When we think of that, peripheral, central, peripheral, if we can't get into central because there's something acutely happening there, we certainly can apply superficial techniques to the peripheral aspects of the condition, and we're promoting edema away from the problem area. It can also be used to relax or sedate the patient. It can help to reduce the perception of pain along the same mechanisms as previous. It is a great introductory technique to spread your oil or lotion, depending on what you're using, and I think you've already talked to me about that. You've talked about that in lab. Effleurage also is a great transitional technique. So in the context of superficial, deep, superficial, you would use your effleurage to introduce and begin your technique. Then you would move into the deep technique, whatever that could be. And then when you're done with the deep technique, you would come back to superficial effleurage to finish it. So that would really fit nicely into that superficial, deep, superficial principle. Contraindications and cautions, of course, cardiac conditions, so post-infarction, which is a heart attack, congestive heart failure, because you can potentially increase the fluid load to a heart that may be struggling. Areas where you have acute and subacute inflammation and pain, you could have damaged or healing tissue there, so we don't want to be working over that with anything. If there is an infection, such as in the area, if you have what's called cellulitis, which is an infection within the subcutaneous tissues itself, the fluids there, and then thrombus, which is a clot, we don't want to be providing that. Those would be sort of local contraindications. And then, of course, kidney pathologies, same as with an infarct or a heart attack, you are increasing load of flow to organs who may not be prepared for that increased amount coming back. So when you're performing it, in this case, you're using oil or lotion, whereas in the superficial techniques, not necessarily. You can do those without or with. Your hands are relaxed. You mold to the client's body. You glide with pressure towards the heart or towards axilla or inguinal lymph nodes. The return stroke is optional. I always liked to use a return stroke. I would sort of do that superficial effleurage towards the direction here that we talk about here with the heart or axillary region, and then almost like a light stroke coming back. That's what I would do. When treating edema, of course, we want to treat proximal first and then repeat strokes towards, going proximal, the principal proximal to distal to proximal. This is where we would apply that towards promoting lymph drainage from an area. Try the massage clinic as is on here. The one thing that's really important to understand, you have the opportunity to go to the clinic and get feedback for yourself. So, you're going to practice in lab. You're hopefully going to go to open lab to practice amongst yourselves. But really, truly, go to the clinic, get an appointment, and get feedback from a senior student who's had a little more experience of a couple of semesters of practice. And they can help work you through it and maybe have a brief conversation and get the feedback that you need. Thanks. That's the end of this first slide set. There'll be another one coming, and you are responsible for these. Have a great rest of Thanksgiving weekend. Thanks.